infection. So we were looking at implementation effectiveness of surgical site infection prevention protocols. And then what we currently are doing, which is intervention and hybrid evaluation of implementing unit-based safety programs based on what we learned from our original analysis. So originally, I got into this work because of a collaboration between the Children's Hospital Association and the Pediatric Research and Patient Settings Network. And so this is a value-based purchasing consortium, but they also have a ton of administrative data on greater than 43 children's hospitals, all payer, line item billing, all discharges. And PRIZE really had the deliverables of both provide stakeholders, the CEOs of these hospitals, with what conditions they needed to take a closer look at in their hospitals in terms of cost and variability. And we really wanted to set an agenda to prioritize inpatient health services research for hospitals moving forward. And when we did this analysis, of course, the high cost, high variation conditions were things like pneumonia, bronchiolitis, chemotherapy, but idiopathic scoliosis was also in there. But definitely high cost, fifth in the cost, mid prevalence, but very high variation. And so this is each row here is a hospital, and the red dots show the average cost per surgery and vary between $50,000 and $100,000. And where there's variation in cost, there's most likely variation in quality. So I felt like it was a really important population to study. So spine deformities are in a heterogeneous population. They can be kids with CP, kids with chest wall bony deformities, children with muscular dystrophy, and other neuromuscular disorders, and even healthy kids with scoliosis. And these patients are at very high risk, many of them for complications, some more than others. So a lot of the conditions I just mentioned, including other medical comorbidities, and otherwise kids walking around looking just as healthy as you or I, like Marfan syndrome or neurofibromatosis, put children at very high risk for infection. But infections that are still preventable events. And so this is an elective surgery, which means there's a lot of time to prepare and put things in place to prevent infection. We really just want to stop progression of curves, improve quality of life and overall well-being. So I think we have a very large responsibility to make sure that preventative care is in place. So with access to a lot of this quantitative data, we found that the outcomes were highly variable. So most kids, when they get readmitted, are for infection. And the high-risk kids, about 5 to 16%. Each column is a different hospital. But even the healthy adolescents, readmission rates at 30 days were anywhere from less than 1% to almost 10%. So obviously, a lot of variation in care that is probably unwarranted. And at first, we started looking at guideline development. I worked with some of the national groups at developing consensus-based protocols for surgical site infection. And even in the years after we implemented these and found that practices across hospitals were becoming quite similar with respect to our protocols, the variation in surgical site infection was still pretty remarkable. So we knew that there was something else going on, which isn't a surprise really from a lot of the experience in adult medicine. There recently, Lucian Leek, who was sort of the father of patient safety, had written an editorial in the New England Journal called The Checklist Conundrum. And so this recognition that all of these protocols, such as the surgical care improvement protocol in adult medicine, as well as the WHA surgical safety checklist, we're having diminishing returns. So you're getting very high adherence to these protocols, and yet variation is still there. So starting to recognize that culture and context can highly influence the effectiveness of implementation. And then this is actually Peter Pronovost, who the Checklist Manifesto by Tulwande was sort of based on. And even he started to recognize this problem with culture and collaboration in getting in the way of effective implementation. And some adult groups had started doing similar sequential mixed methods type analyses to try and get some of these cultural issues. This one was for acute MI. They looked at 11 adult hospitals, did semi-structured interviews, looked at protocols and guidelines and found that they were not sufficient, probably necessary, but not sufficient for effective care. And then reinforced some of these ideas of culture and collaboration, alignment of goals, data use, and local unit level improvement efforts. And so a lot of this is what we based our pseudo-hypotheses on. I think we really wanted to keep our minds open that themes would emerge in our surgical population, but based our study on these concepts. And so our overall objective was to determine the barriers and facilitators to effective surgical site infection prevention, looking at high versus low performers. So exactly how was discussed and introduced at the last conference. First, we needed to quantify the risk standardized rates of infection so we could find our high and low performers, then collect qualitative data using semi-structured interviews and some observations at the hospitals themselves to try and explain some of the differences and differentiate these hospitals. It did comparative analysis with a pseudo-grounded theory to find the themes. And our overall goal was to get an actionable bundle of targets for organizational factors to really go in and inform these hospitals on how they can effectively implement care. And so the overall design was first to group the hospitals by performance, and then we interviewed 150 total staff and families, and for Julie this was quite a Herculean effort that was done in a very short period of time. We looked at the protocols and did observations, as I said, and we also did some team step surveys, which are standardly used to measure teamwork and culture, just to see if we were detecting the same sorts of things in the commonly used surveys versus our qualitative data. And as we all know, some patients really are sicker, and I really think that it can't be emphasized enough that if you're going to do some type of mixed method study like this, your quantitative data has to be right. Otherwise, you're going through a very large amount of work to get what might not be the correct answers. And so there are a lot of patient risk factors, pulmonary, whether or not the children have shunts or G-tubes, nutritional status, a lot of things that we could measure in the data that we needed to control for, including the surgeries themselves. And so we took great care to get at the answer to the question, how well would the same patient do at hospital X versus Y? So what is the contribution of the hospital? We didn't really care so much about the observed rates across hospitals. That wasn't going to differentiate exactly how they were doing for their patients. We needed to know what the hospital contribution may or may not be to risk. And so we used some statistical methods that are commonly used in adult MI mortality work as well, to look at the predicted versus expected ratios. And this is what we ultimately found. Looking at it descriptively, the pluses are the observed data, which could go anywhere from 0 to greater than 15%. And the circles are the X's are the expected rates. So basically, if you looked at how the case mix of patients would do across all hospitals, what their outcomes rates would be. And then the circles are taking into account the clustering of patients within hospital. So the lines basically become what the hospital does to add or reduce the patient's risk. And so the left-hand side are hospitals that are doing better than expected, the right-hand side worse than expected, and the distance of the line shows the degree of risk that the hospital either adds or takes away. So while we couldn't get exact statistical significant differences across individual hospitals, we could take a look at hospitals that had relatively large lines in either direction that sort of were at either end of the spectrum of performance. And so we selected 6 hospitals to do our interviews with. So I originally based the interview guides and my thought about how this care is provided on the systems engineering for patient safety model, thinking that I really wanted to target specific factors. I thought, well, maybe there's a way they're using the tools or the EMR. Maybe there's some organizational factor or how they do their tasks and the people that they have doing each of the roles in the continuum of care. And it really was not that simple. I found that we had much more of an interplay between all of the factors. Organizational culture was huge, engaged leadership, interdependence. So the idea that I understand that your job is important, my job is important, the next person's job is important, and that we all do things separately in the continuum. And then accountability and just culture, we're finding we've sort of shifted back and forth in hospitals from the no blame culture to the punitive culture and back and forth, and really getting that whole idea of accountability and culture is highly key to performance. And some quotes that we had here for the high performers for accountability. Sometimes if there's a staff member where they feel the surgeon is not up to par, they bring the concern to me, and then I'll speak to them, the team member, to educate them on the expectation of certain procedures. So definitely just culture, people feel comfortable speaking up at all levels. And then the low performers, usually all our spinals have what we call standardized orders, have a doctor, we know their orders are going to be a little different. We get so used to one routine and then another patient comes in, different doctor. So this acceptability that people just don't follow the guidelines, and that's just the way it is. And so, and not recognizing that can be a big problem. So interdisciplinary team function was important, integrating trainees. A lot of these hospitals have residents and fellows and other types of trainees, and educating them was important. Workload, not tolerating task absorption, where one person or group of people ends up taking on multiple tasks that then they have to do in series as opposed to parallel with other team members. And then multidisciplinary workflows where specialties work together, each to be accountable for the tasks for the patient that that is in their area. And so for integrating trainees, it was a very big theme. High performers, there's a lot of time spent making sure when they come to the hospital, they understand the protocol, they understand the process and the pathway. Whereas in the low performing hospitals, there really was this sort of throw the hands up in the air that the residents are just going to screw everything up, so whatever, you just tolerate it. I think the hard part of working in an academic institution, the residents and fellows, they come in, they think, I'm not going to do it that way, because that's not what I think is right. They don't want to follow it, or they don't even know the protocol. So just an acceptance or a hopelessness that that's just the way it is, despite the fact that I think we can all agree that that's probably not the best care for our patients. And then standardization and reconfiguration. So beyond protocols, using data, data reporting, and then co-design and collective appraisal protocols. So every member gets involved, but there's also data so that you can fight change fatigue with these types of protocols and changes. You collect data before, you can see if there's a change, the data is reassessed. If things aren't working, people have hope that we're not going to keep making them do the same thing over and over again if it's not working, and that can really fight change fatigue. So the high performers here, the development of that pathway, there's pharmacy, infection control, involved infectious disease, everybody that touches the patient has had input in the whole process, and this was a common finding. Whereas low performers, timeouts in the operating rooms, where the nursing staff and OR nurses established what these timeouts should be. I think they've gone overboard. The surgeons really fought back. And for those particular hospitals, the adherence to the timeouts was very low. Even though in the surveys they wouldn't say that. So, and then for the observations, there were a lot of things on the floor that we were able to observe that may or may not have been different, but the operating room function was really a demonstration of how the whole team functioned and the thought about process and process integration. This is a picture from Seattle of how they organized their operating rooms, and that's one of the high performers. And so there was strict timeout adherence, purposeful communication, so a lot of teaching going on. So that kind of gets with the integrating of the trainees, and I think maybe something to do with people really paying attention to what they're doing as they're teaching trainees. Supervision, physical organization, and what goes with physical organization was purposeful movement. Everyone had a space where they're supposed to do their job. They had their jobs that work in parallel with other jobs, people not wandering around the room, not having purposeful action and taking care of their patient. So with all of that, we really wanted to think about how we could, a system that we could implement to help hospitals that were low performers and had a lot of these barriers, overcome these barriers and start implementing effective care across their continuum. And so we identified what was Peter Pernovas had shown before, his comprehensive unit-based safety programs, and trying to adapt those to our surgical units. And so the CUS model is also a collaborative effort that is now sponsored by the AHRQ, works a lot with corporate organizational models, but geared toward working with frontline providers, and based on the concept that culture is local, improvement is local. So really aligns well with our ideas about frontline engaging with leadership. And then, of course, it's out of the box. So we weren't reinventing the wheel or creating anything new. Our goal was to implement and evaluate the implementation of this and adaptation to these hospitals. And this just shows how very systematized this is. You have some modules that you present to the team, assembling the team, engaging with stakeholders, safety science training, which I'm surprised was not something that was done across the board, sense making and identifying defects, and then teamwork and communication. And so each of these modules in some form was given to the units. And once again, also easy to get them to buy into it because there's a lot of evidence for this to work, both for class reduction of central associated bloodstream infections in ICUs and adult ICUs, and also in colorectal surgery. So there's been reductions in delays and disruptions and lower mortality with implementation of these programs. So it's easy to get the surgeons to buy into them, seeing that they have been effective. And so the study design that we're currently in the middle of, it's a very long process. We did a staggered start, step wedge study design, where we launched at different times for each site. And we started with the audit feedback on the barriers. So each site had a report based on what we found from the qualitative data. And then we would go through the modules in order, as well as facilitate meetings and work with the teams on projects. And a lot of this was problem-based. We allowed them to choose the project that they wanted to work on so that they could align well with one another and integrate the skills that we were teaching them in the program. And our study outcomes, both implementation effectiveness, so looking at fidelity to the program and how we needed to adapt it, acceptability, and trying to define some core elements. So when you do these studies with the high and low performers, the differentiating factors, you still don't know if individually that they are each equally as effective. So it's really just a bundle that differentiates them. And you still need to do work, I believe, in implementation effectiveness to tease out which ones are most contributing to the outcomes. And then looking at the internal metrics, looking at the overall relative performance data, that graph that I showed in the beginning, we've been repeating that in cross sections and just seeing if the hospitals are actually moving on that graph from being low performers to high performers, and seeing that the high performers are actually staying in the same place. And then at the end, we wanted to improve organizational barriers. And originally, the aim was to develop a survey that we would just so beautifully feed back to them, and it would identify these very discrete fields we can ask about, and we could do the survey at the end and see how things have changed. And so for our internal metrics, which is really what we're focusing on right now, this is just an example. One team focused on central line days and working from an interdisciplinary way that to reduce central line days. So kids were keeping in their central lines after the surgery for about 67% of their stay. So basically they were staying in until almost the kid was ready to leave, and then somebody would pull it out because they just would notice that they didn't need it anymore, which is really not something that is a policy for how we treat other children with central lines. And so we really, when we approached this, thought about those barriers to implementation that we had identified. We first started, as with some other projects, with data collection and appraisal, so showing people the data, starting to automate collecting it. We also did some surveys of people's thoughts on taking care of central lines. We did process mapping and surveys and clarifying the risks versus benefits. So talking about workload among the nurses and the other providers. What does it mean to not have the line? What does it add to your workload to take the line out, to leave the line in? How's the conversation with the parents? We really got down to what this means for everyone's jobs. And then we identified multidisciplinary targets. So identifying everyone's responsibility and interdependence and workflows in terms of when a patient's transferred, how much of a barrier is it to take it out beforehand versus letting the patient get it out afterwards. And then clarification of the removal policy, who's responsible, who can do it, who's accountable for getting these lines out. And then to that end, we co-designed nursing education skills labs to try and disseminate the information about new policies and accountability, and empower the nurses to be able to make decisions about removing the lines and feel comfortable to remove the lines themselves. And this is just an example of our skills lab. I think that what's interesting about this in terms of co-design is that we really were thinking about showing videos and showing people taking the lines out, but when we talked to the nurses, they really thought that the tactile experience of cutting the sutures and also taking a look at lines that maybe something doesn't look quite right with was what would make them feel more comfortable. So these are just sort of fake central lines sutured into the buoy so that the nurses in the skills lab could get practice with cutting the lines and feel more comfortable with that. Cutting the sutures. We don't want to cut the lines. That's what we don't want to do. And so for this particular project, we reduced in half by 1 day the days the lines in, and in half the duration of the length of stay. And then also measuring balancing measures so we can reassure people that that we weren't causing harm by kids needing new central lines or other events happening. And then just showing back the data to the team about what did our interventions do. And if you can see with this run chart, it's pretty impressive. The variation went down as well as the number of days of central lines went down and stayed down with our interventions. And this actually got hospital recognition. So these early wins really built a lot of teamwork. And so there was some degree of qualitative evaluation as we do this process. So we haven't been coding specific interviews, but we do debriefings and facilitation with the teams and try to observe what some of the feasibility issues may be across other centers. One thing that we have noticed that feasibility for this data collection process requires dedicated staff for data collection and evaluation. So when we go into sites and talk about how you implement these programs to be effective, that's something that definitely needs to be addressed. And then acceptability was really dependent on institutional alignment. So staff and people in change groups and staff getting training in how to manage up or pitch or find alignment with hospital leadership was also huge for them to get wins. And something that really isn't part of the cusp training as much as was more part of the facilitation and coaching. So that's why I think one of the core elements will be some type of peer support, facilitation, and coaching when we finally implement this in larger numbers of centers. And so I did mention the survey, and this was a really beautiful finding that we had. And we developed this survey and we fed it back to more of the sites and tried to look at some of the differentiating factors that were lining up with our qualitative data. And we did find there was huge social desirability bias on the safety culture questions. So sites, actually, it was the opposite of what we'd expect. Sites that were high performers often sort of would answer, well, you know, we really could do that better, or we could improve on this, I guess. And so they would answer more towards the negative side, whereas the low performers, I believe, maybe because of a lack of awareness or just not wanting to say anything, oh yeah, you know, these are great, yeah, this works great. And then the conditioning about known metrics, of course, which is probably why the checklists said that don't always work. Everyone had protocols, great communication, they did 100% of the timeouts, and some of these were the hospitals that we had done the qualitative work for, and we knew that those answers were not accurate. But some of the structural questions did align, things like OR equipment dysfunction, resident education adherence. So factors that really aren't in the guidelines and talked about a lot did line up with our performers. But still, really, we recognized that we were going to need to use qualitative assessment, or we are going to need to use qualitative assessment as an outcomes measure so that we can measure changes or shifts in the themes from the original data to the post intervention data. And the other thing that we learned, as you can tell, I did not mention the family data and anything that we had done. And mostly because the families were kind of unaware of the surgical team functioning. I had this image that a family and their interaction with the team would be one of the big factors in performance and indicators for performance. But the family experience was not correlated with hospital performance. So there were two separate domains in quality hospitals with high performance, some of them with high performance, low performance, excuse me, had very high patient and family-centered care and vice versa because they had efforts that were separate, targeted towards the family experience. And in some cases, the interventions to improve patient and family-centered care are actually having the opposite effect. Sometimes families describing family-centered rounds as being traumatic and anxiety-producing. And so, and then as well, there were a lot of outcomes that were not being considered by the surgical teams and considered in the whole concept of performance that the families were mentioning. So an enormous amount of golden information we learned from families that will contribute to our future research in terms of integrating patient and family-centered care into other patient safety efforts. And why this is important and why I believe that these qualitative analyses will make huge contributions is surveys that are being done for U.S. News and World Report, steps to engage families and patient and family services or checkboxes that are filled out, but we don't know that they're the right steps and we don't know that they're the right services. And we're hoping that explorations that these qualitative studies have led to will hopefully someday be able to contribute to improving these metrics. So remaining study goals, we're going to complete our 18-month follow-up after the interventions for the CUSP team implementation are complete. And then we will commence a more qualitative data collection. And even though it's a longer process, I believe that will be much more valuable to future implementation of these programs at different surgical sites. We will continue to pull the quarterly rates so we can show hospitals their relative benchmarking and how they've moved in the performance realm, although the ICD-10 is giving us a lot of challenges. And then we'll follow sustainability. And ultimately, we want to create an implementation guide for a SUSP that has incorporates the core elements, the things we know that are most effective so that teams are successful. And I think another reason this is very important is that during the course of this study, AHRQ actually, I think Hopkins got the contract, a $10 million contract to implement surgically based safety programs in adult surgeries. We did talk to them about having pediatric spine as part of their conditions, and they were not interested at this time. They said get back to us for phase 2, but we are hoping that some of the work that we're doing can help contribute to the toolkits that they will be developing for surgical units. And then, of course, we have a ton of work with integrating families into a lot of this work. We've actually started, part of our final parts of our aims, we're getting families onto the CUSP teams, which is actually I think CUSP in general has tried to have modules about family integration, but doing some coaching about getting families on the team. And so far, this has kind of blown my mind with what we've learned in terms of how to integrate families into the safety improvement, not even just in family-centered rounds, but talking about managing central lines and other things like that. And then our ultimate goal is research, education, accountability. We would like to do a lot more dissemination and implementation across hospitals that take care of children like this. So annually, we have a Safety and Spine Surgery Summit that's put on by leaders in Pediatric Orthopedic Society of North America. And I was joking with Bethany that they're getting impatient that they have the pace of this work every year. I'm sort of only presenting a little bit more data, but this just takes time. But they have seen it as very high value, and so it's been a great platform for us to get our work done. And then we have started a foundation called the Safety and Spine Surgery Project that's geared towards education and really peer mentoring and effective implementation of these programs and guidelines. Unfortunately funded by all device companies, but maybe we can grow that into better funding. And so I really want to thank the team that we've been working with, just from all across the country, from these hospitals and from different networks. We've had a huge amount of participation. And then, of course, Julie and Michelle and Carter and Sarah Newman, who have done a ton of this qualitative work, which I couldn't do, and mixed methods work I couldn't do without them. And so with that, explaining that research journey that is still ongoing, I'd love to hear any questions for discussion. Yes, Allie.
I have two questions.
Okay.
First of all, when you, for example, in low performing kind of positive, how consistent is that? I mean, did you see a lot of variation, or was like the culture kind of consistent? And I guess conversely on the other.
Yeah, well, one thing I say that there were really no unique and beautiful snowflakes. I mean, I think that Julie always says they were the bundle of things that differentiate and were duplicative. They were sort of all there or all not there. I could always tell, I mean, I always said, well, an interview for a high performer always ended with, just let us know what we can do better. You know, the same kind of attitude. And whereas, you know, the low performance, it would always deteriorate into the airing of the grievances, you know, these very more toxic cultures. And one of the things we did look at was turnover. And turnover was another very incredibly high at the lower performers and incredibly low at the higher performers. So very stereotypical findings. And I was surprised, actually, at that.
I also wanted to ask about the role of trainees. It sounded like sometimes that was helpful, sometimes it was not helpful in those two environments. But did you, is that true, or what would be your summary about how trainees affected the culture?
You know, I think I learned a lot about that during the observations. So I think that the training, the appropriate integration of the trainees not only helped the trainees provide safer care, but there was something about the teaching and the education and what they were doing to the trainees that I think also created safer care by the senior providers. I sort of thought going into an operating room, if there was a lot of chatter and noise, that was going to be a bad sign. And I found that the more chattering in some of the ORs was all teaching, and really that it was something that we found more in the high performance. Did that answer your question, Ellen?
Yeah, it sounds like there are reasons why it's either helpful.
Right. It's not the trainees themselves. Yeah.
They're not getting that.
Assassins, junior assassins. Yeah.
Okay. Yeah.
Lisa, can you talk a little bit about your data analysis process? You mentioned it does take a long time. Can you talk a little bit about your experience and how you gathered your team together, how that went?
So yeah, it does take a long time. I think the most valuable piece of it is the group discussion, the comparative process, constant comparative process. Especially as a provider coming in, it's really easy to start biasing myself towards different things that I think, oh, this must be the key, right? This sounds so good. And then having a qualitative team who can say, you know, no, actually, like when we really do go through the coding, this is something that does not differentiate institutions. And so that constant review of those items. And I've had colleagues that want discussion, they want to have some guidance on how to design their studies, and I only have enough money to do the high performers, and I can't understate how much that is missing, and that you need a team of unbiased coders to just sift through the data and find those elements that truly differentiate. And so we used Atlas. Karen did a lot of hand coding. So there was a lot of printing out of the big papers and trying to code and then sitting down together and seeing. I think we did some dual coding, if that's what, to see how we match up. But only, I think that would help us keep from drifting and find that sometimes when the bias would creep in, you start seeing everything as a nail, hammer nail, and doing some dual coding just to keep us on track with our codes is also very helpful. If that answers your question in terms of the process. Yes.
Yeah, for sustainability, could those measurements be institutionalized into electronic health records?
So one of the aspects that we had started with was that we were going to dashboard for these teams and help them produce their dashboarding, and we found that each of them had such different ways of collecting data that what was more important was us promoting them getting people to do the data internally. So I think that a lot of institutionalization is going to be dependent on continued support for those types of roles. And
you had mentioned the social desirability bias component of some of the healthcare evaluations that you did. Is that something that you found any ways to minimize, or you just have to accept that that's something that happens in this evaluation?
for the qualitative, we did not find the social desirability bias. I mean, I think that a good interviewer, and I would be usually, by the time you get 10 minutes into the interview, the social desirability bias would go out the window, and you would just get what I would find to be closest to the truth. It's the surveys, the quantitative surveys, that we couldn't get around the social desirability bias. And for certain parts more than others, but the more conditioned I think that the hospitals were towards certain national metrics or certain ideas, the worse that it was. And so getting around that, I don't really know that you can. I think that there are some, especially looking at implementation effectiveness and program development, I really feel if you're not doing some kind of qualitative exploration, you're in danger, I think, of missing some very important themes and results. Yes, Al.
So if you were advising a hospital on the fastest, most efficient way to figure out what the problem is, it would be observation, qualitative, and gather around the survey. I mean, do you think you learn more by, in terms of, since you were able to sort of diagram what things matter,
Mm-hmm.
you learned more about observation by qualitative, or could you do one without the other?
I think observation was very powerful. And for one of our sites that was kind of having difficulty getting to the idea of sense making, instead of wanting to say it's because, wanting to boil everything down to one problem, we had someone go in and do observations in the operating room and do maps, flow maps, sort of like a time motion exercise. And that was incredibly powerful to then start the team doing some interactive process mapping about what's going on in every step. I mean, I think that the process of that discussion is kind of this qualitative frontline wisdom process, but it really was sparked by someone outside of the group observing.
Can I add? Do you mind just real quick? I think this is a mixed method seminar just to emphasize. I think that Elisa just described it. In some ways, it seemed to have a lot of power with the teams for that information because it had a quantitative and qualitative component.
Right.
And that message was so powerful with the medical team because there was, for that particular one, the time was what they were worried about. So there's that quantification of how long from wheels in and wheels out for surgery, and then the qualitative observations are combined in a mixed method style, and now it's very effective with people really understanding and getting engaged.
Absolutely. Anything else? Well, thank you. And thank you so much, Bethany, and thank you, Megan, and thank you, Julie. I'm really excited to keep moving this work forward using the methods I will get even stronger at in this course.